that is a function of position. It's not a function
of knowledge.
It's not a function of knowledge.
No. I beg to differ. Administration is not about being a doctor or a pharmacist. It's about being an administrator. And that's if you're saying that a CMD has to be a doctor, how much of pharmacy does a CMD know?
Hi guys, welcome back to my YouTube channel. My name is Rufai. I film videos about pharmacy school, my faith, my lifestyle and school life in general. If you are new here, welcome. Make sure you check out my other videos and do how to subscribe before leaving. If you are not new here, thank you so much for coming back. I appreciate your love and your support on my videos. So straight to the business of today. As you can see by the title of this video, we'll be doing something totally different. The title of our video is the battle between medicine and pharmacy. So low-key, if you're a medical student or a medical doctor, a pharmacist or a pharmacy student, you know about this underlying battle that we're going to talk about here today. In the video of today, we're talking about the root cause of this problem, our reality here in this school and in the field, and we'll be providing solutions to foster a better relationship between medicine and pharmacy in school, in the field, and beyond the field. So if that sounds like something you're interested in watching, stay tuned.
And oddly, is also an health worker, so can also become a CMD.
And oddly, yes. Note, I said health workers that have administrative qualifications.
So they can also go for, MBA or after some time due to another thing.
Are there not systems where hospital administrators with degrees in health administration actually administer and see to the runnings of the hospital? You have head of departments in the hospital, right? So if you're saying that a CMD has to be a doctor, how much of pharmacy does a CMD know?
How much of pharmacy does it need to be a CMD?
And that is why I'm saying, that is why you have the head of pharmacy, who is a pharmacist. So basically what I'm saying is, what you need to do is...
You have my question, sir.
Okay.
You said that if a doctor has to be a CMD,
okay,
that how much of pharmacy does he know? And I said that how much of pharmacy does he need to be a CMD?
Now, for you to actually claim to know so much about pharmacy, you have to be a pharmacist.
You still didn't get my question. You are trying to say that someone... Your problem is that, okay, that how much of pharmacy does he know that for him or her to oversee and to do where he was a pharmacist? Good. And I said that how much of pharmacy does he need to administer pharmacists or to administer everybody in the hospital?
Not so much, which is my point. So if you claim that doctors have to be the ones that have to be CMDs, I'm pointing out the fact that there is a branch of the hospital that they don't know so much about and they are still administering over it. Do you get? Because you have heads of departments that answers to you, who are professionals in this field. Do you get what I'm trying to say? So to be an administrator, you understand, is basically to have an idea. And that's what I'm saying, somebody who studied health administration, because I know there is a course that is health administration, you understand? So all you need is an idea. You have people that are professionals in this field that are heading these fields. You're a doctor. I know there are some clients you delve into that I will be lost. Definitely. I'm a pharmacist. If I delve into some clients, you definitely will be lost. But I believe that as health professionals, we have a relative table ground that I will say some things and you will have an idea, right? A nurse will say some things, you will have an idea. You will say some things, I will have an idea. And so the idea is what is required. Administration is not about being a doctor or a pharmacist. It's about being an administrator. And that's why I am saying, once you have a health professional, which means to a reasonable extent they have an idea of what the health system is about, who probably has the required certifications in health administration, this should be allowed.
So the question is, who is allowed?
Now, whether we like it or not, we know this is a game of politics, and there are policies in place. See, and I feel this problem is peculiar to Nigeria. You understand? This problem is peculiar to Nigeria. Yes, we probably know some policies as students, but see, there are still a whole lot of things that we are not exposed to yet, and probably when we get to practice, we'll begin to see. You understand? But I believe that if something has been in a particular way for years and no change has happened, then I feel we should all have a open mind. I am not saying doctors should not be CMDs. I'm saying all other health professionals should be given the opportunity. You understand? To also explore this.
So what is the role of doctors in preventing other professionals from becoming CMDs?
You know the politics is there.
How much the politics is there?
That's the point. I am not in the system yet.
Exactly. So I'm saying that it means that number one, your claims are subjective.
Okay.
Number two, it means that they are based on what other people, because basically all that you might have said must have been for maybe things that people that are also pharmacists or people that are also having the same agitation, those things that they have said. I also talk from the viewpoint of people that talk about my own bosses.
That have told you stuff, right?
So, which means that they might have spoken from the bias that they have
developed.
Okay. Yes. So the question is this: who has prevented others from aspiring to be that?
I feel if we do our research, we probably will be able to dig up some policies, anything like that. So we might not have the time to actually do that now. But I feel like if we both go back and do our research, we'll be able to dig up some policies that is causing that prevention. For example, there was a time they said only consultants can get to that position. Okay. You understand? And they were saying pharmacists were not consultants.
Sure, of course.
You understand? Yes. Now we have consultant pharmacists. Okay. I don't know if you're aware of that.
I wouldn't say I'm not aware. I wouldn't say I'm aware because the question is we have consultant pharmacists. Okay. But as the role, the title has it been, I wouldn't know. You might want to educate me on that. Has it been ingrained into the civil service that we is a consultant pharmacist?
Yeah, in some states. I don't know if it has been adopted federally.
So my question is this.
But I know some states have adopted it. I know Lagos State has. I know Taraba State has.
So the question is this: what is the role of a consultant pharmacist compared to whatsoever used to be the highest rank?
Okay.
As pharmacist. Okay. Whatsoever used to be, I don't know what the highest rank is in pharmacy. So what is the role? Is it just a change of name, or an additional responsibility? So if it is a change of name, what's the point?
It's definitely not a change of name.
If it's an additional responsibility, what is the added responsibility that a consultant pharmacist has now, which differs from whatsoever position? I don't know if you get my point.
I get your point.
Whatever position, whatever role the highest person in pharmacy had before.
Alright, so now
I really want to learn.
Now I am not in the civil service.
Okay.
You understand? So I might not be able to say this role is what is applicable to them in the civil service.
But you are taught leadership and management.
Yes. Relax, let me finish. I might not be able to say this is the role applicable to them in the civil service. You understand? But one thing I know for sure that comes with consultancy is specificity of knowledge, which I think is basically what is applicable even in the area of medicine too. Yes, specificity of knowledge. So you are for example, you are a consultant obstetrics and gynecologist. You would definitely have knowledge of other areas of medicine, but you are a god when it comes to O&G, right?
Was that knowledge, was it not existing before?
The new knowledge in pharmacy.
I mean the knowledge specificity
in pharmacy or in medicine.
In pharmacy.
No, it wasn't. It wasn't.
Okay, so before now, everybody was just the jack of all trades.
No, it basically with your B-Pharm, what you obtain from your B-Pharm is basically what you obtain from your MBBS. I don't know, is that what you guys get? You understand? So you have like a broad knowledge of almost everything.
And MBBS is not a consultant, okay, you know.
I understand you. You understand? I know. But you guys have a broad knowledge of everything. Now for pharmacy, after your B-Pharm or your PharmD, depending on what area you want to delve into, you could go do your masters, do your PhD, you understand? Or maybe if you have a B-Pharm, you could go do your PharmD and just delve into the clinical area. You understand? But when you do, I think the consultancy course is about 5 or 6 years. It's a 5 or 6 year program in the West African Postgraduate College of Pharmacy. You understand?
After qualification.
After your first degree. You understand? And I think depending on which area, some people require you to have a master's first before you can then delve into consultancy. And then for some, you can use your B-Pharm to go into it, but then you would run some other programs in between. Okay. You understand? To get my point. So there's a specificity of knowledge. So you have, say for example, you have a consultant cardiac pharmacist who is specific on drugs that have to do with the cardiac system. You understand? And whether you like it or not, for people that have been to other clients, will appreciate the specificity in this knowledge. Because I'm not a doctor, or I might not be able to say much about some things, but I feel like there is always, say for example, let me just give a practical knowledge of at least basic stuff I have. There's something called off-label use of drugs. I don't know if you heard about it. Okay. So now, these are the use of drugs that are different from what everybody knows this drug to be used for. Now, this knowledge, yes, some doctors may be privy to it, but except you want to be biased, you agree with me that pharmacists have a better knowledge of these things. You understand? Now, if you're a consultant, say CVS pharmacist, for example, you might get to know some of these things way better than even a general pharmacist. So basically, if you are maybe a doctor, you are managing a CVS condition, my contribution as a consultant cardiovascular pharmacist will go a long way in your choice of drugs, because I have a better understanding of the mechanism of actions of these drugs, the side effects, how they work, what to expect from the long term of use, what to expect from the short term, and even how you can manipulate a lot of these drugs to get a better result.
That's my question. Okay, is that before the advent of this consultant pharmacist, does that mean that those who were at the peak of pharmacy practice
Okay.
that there were no people who had this specific.
There were people that had it, but the degree in quotes was not recognized by the government and wasn't incorporated into the civil service.
Is it the degree or the knowledge?
And maybe the knowledge has been applied. I wouldn't know. Like I said, I'm not part of the civil service, but I know it wasn't given the required recognition. So at the end of the day, even somebody with a consultant, somebody with a consultant pharmacist cannot even climb above the cadre than somebody who is maybe with a master's in pharmacy or something, because there is no higher cadre to climb to. I don't know if you understand what I'm trying to say. So because the civil service doesn't recognize that, but I know some states have begun to recognize it, and a level of upgrade has been, attached, to being a consultant pharmacist. But we know that we are in a country where the health system is a bit fucked up. So
okay, so I want to bring up something.
Okay.
And this is one of the issues that we deal with as doctors to be, as pharmacists to be. If you know,
okay.
but if you don't know problem, can you run me through the steps? After when you become a pharmacist,
Okay.
the steps. And when you do that, now being a consultant pharmacist,
Okay.
where do you fit in? I mean, you come after which of them? Do you come up after the highest? Do you get my point?
Like what the highest that is obtainable before consultancy.
So what's the highest? Now let's leave consultancy.
Okay.
If you are climbing up the ladder,
Okay.
what's how do you go in from pharmacy to superintendent pharmacist to Miss company?
Okay.
So
it's a function of
yes.
now it's a function of where you're practicing. That's what I wanted to say.
Okay, sure.
You understand? So if you are in community practice, you're probably the alpha and the omega of everything.
Let's say
You
hospital
understand? So let's say in the hospital setting. So you have say maybe intern pharmacist,
Okay.
then you have
Copper,
pharmacist, then your normal pharmacist,
Okay.
then probably head of units.
Okay.
You understand? Then head of units, then probably you have your chief pharmacist, head of units, then probably head of the pharmacy department in that hospital.
Okay, so what's the highest? No,
For the hospital setting, it's in a particular hospital, it's always the head of the pharmacy department.
Good. So the head of the pharmacy, I mean in terms of your personal qualification,
Yes.
So head of pharmacy is that your personal qualification, like superintendent pharmacist.
For you to be a pharmacist, you have to have a degree in pharmacy.
You don't get my point.
Relax, I'm coming. You have to have a degree in pharmacy. Superintendent pharmacist is most times applicable in the community setting.
Okay.
You understand? You get. So, but in the hospital setting, for you to probably even be a chief pharmacist, all you need is a degree in pharmacy. But for you to upgrade to the level of, head of pharmacy department, you must have an additional degree, maybe an MBA, you understand, or a degree in clinical pharmacy. I mean, an additional degree in clinical pharmacy, maybe a master's in clinical pharmacy, and all like that.
So if a consultant pharmacy comes, if a consultant pharmacist comes,
Yes.
So in which of those organogram would
Now,
fit into?
what we are saying now is this: that as a consultant pharmacist, you understand, you have what it takes to even be above just the head of pharmacy unit, which the civil service have not created. Do you get what I'm trying to say?
Good. It means there is a function of position. It's not a function
Of knowledge.
It's not a function of knowledge.
No. I beg to differ. Now, as a consultant pharmacist, you know what the HOD of pharmacy knows, and you know more. Like I said before, consultancy is a function of specificity, right? So, a consultant ophthalmologist knows more about the eyes than any other kind of doctor, right?
The other kind of doctors, that's what I'm going to.
The other kind of doctors know about it.
They are always the other kind of doctors of that same ophthalmology.
Mm-hmm.
They are younger doctors, like senior registrar, junior registrar.
That are in that branch. But if you bring a maybe say a CVS doctor, are you saying he's clueless about the eyes at all?
Of course, no.
He has an idea. Basically the same thing. You understand? So for pharmacy, you have your B-Pharm, which is the same thing as your MBBS. You get. Now, I progress to have a master's in, say maybe clinical pharmacy now, and maybe I major in cardiovascular drugs. You understand? In clinical pharmacy, I have a master's in clinical pharmacy. You get. I have a PhD in clinical pharmacy, still under cardiovascular drugs. A consultant is higher than because he has more knowledge, even than a PhD.
Okay.
You understand? Then there's also the bias of people with PhDs delving more into academia. I don't know if that's what's obtainable in medicine, because I don't even think medicine has that line, except you want to delve into academia.
So do PhD.
Okay, you understand? So, but you would have a consultant. Most times, consultant pharmacists are more clinically oriented. Do you understand? They are more clinically oriented, and so they have specific knowledge in specific areas than people doing that part but are of lower qualifications.
Okay.
Do you understand?
I don't want actually. I asked observations, but I think because of the time.
Okay.
But let me now ask you a question. As a consultant pharmacist,
Okay.
in CVS for instance,
Okay.
who sees the patient?
No, the doctor sees the patient.
So what is the role of a consultant pharmacist?
Good.
Which an other pharmacist would not have done.
Good. Now, like I said before, we have a health system that is completely.
You get my point.
I understand.
As a cardiologist,
yes, yes.
You get that what is no? You said that I asked you that who sees the patient.
Yes, I said the
you said the doctor sees the patient, the consultant cardiologist sees the patient.
Yes.
And I said that after I've seen the patient, what exactly would a CVS consultant pharmacist do?
Okay.
That whosoever is maybe the head pharmacist that you said is the head before would not have been able to do.
Good. Now, when like I was saying before, I said we have a health system that is a bit messed up in Nigeria.
Okay.
You understand? Which everybody will agree with.
Okay.
But what I'm saying is this. I'm not a doctor, but at least I think I have 1 or 2 ideas. There are some conditions that are rare, right? And they're still particular. Okay, so for example now, if a patient has a rare heart condition, who would you most probably refer such a patient to?
A rare heart condition?
Yes, a rare heart condition.
I refer to the cardiologist.
Yes, the consultant cardiologist,
Sure.
right? Good. Now, for rare conditions, you have rare drugs.
Okay.
Right? Your cardiologist knows everything about probably the rare condition.
Sure.
And I'm telling you that a consultant pharmacist knows everything about the rare medications you use for such rare condition. That's just one. Now, what we need to understand is that drugs are poisons.
Sure.
And they're dynamic.
Sure.
You understand? A leverage a pharmacist will have on drugs over a doctor is a doctor will probably know that this drug can do this. A pharmacist will know that that drug can do more than that. Do I understand the disease like you do? No. Do you understand the drugs like I do? No. And that's where the teamwork comes in. Do you understand? I've had a doctor, I've seen prescriptions in community practice where doctors prescribe aspirin for asthma patients. Am I blaming the doctor? No. I don't know what condition such prescriptions were made. But since such a prescription, there's a red flag in my head. Because I understand that drug, right? Maybe not the disease condition. And so it's my place to hello doctor, this and this cannot really work. Why not try something else, right? Even though we know that in practice, of course, this is not applicable to all doctors, but we know there are some doctors that make a big deal out of it. You understand? At least I know 1 or 2 people that have even lost people due to this. You understand? But that is where the teamwork comes in. So I am a what's the word now? I am an authority when it comes to drugs. You are an authority in disease conditions. Bring your knowledge, let me bring my knowledge, and we'll give the patient a better therapy. Do you understand? Yes, we know that we are in a health system that has not paid cognizance to the importance of such conditions. I mean of that additional knowledge coming from pharmacists. And I feel like it's because effect of drugs most times are not seen firsthand. Or maybe the way I would see the effect of drugs is not the way maybe doctors and probably other patients will see effect of drugs. So we don't really place premium on what drugs can do. You understand? So I believe if we are in a society where how people die and what causes their death is paid more attention to, trust me, quite a number of deaths that happen in this country can be directly or indirectly attributed to drugs. And I'm not talking about the abuse now. I'm talking about wrong medication use and many other things that if you have a pharmacist in the picture, you understand, these things can easily be solved. So yes, there's a problem with the system, but there's also a problem with the fact that we as people and even other health professionals don't see the importance of what a pharmacist does or what a pharmacist will do. And I think I would not be wrong to say that this specificity knowledge cuts across other health professionals too. I don't know if there's consultancy in nursing in Nigeria now, but I feel like if you have a consultant nurse, what she will be bringing to the table will be different from what somebody with just a nursing degree will be bringing. And so I feel like if we now start paying cognizance to those additional, knowledge that these other professionals are bringing, we probably would have a better healthcare system and will deliver better. And I mean, this is even to the advantage of the doctors because errors will be reduced. Because you would imagine if your prescription is passing through multiple tables, there's a higher probability of picking errors and correcting them. There are a lot of hospitals in Nigeria where pharmacists don't even have access to case files, including our school here. Except we want to lie.
Do you mean staff pharmacists or pharmacy students?
Even staff pharmacists. Make your findings to the case files of patients.
Were they sent away when you have access to it, or they were told not to come around to it?
That's not what I'm saying. Don't get me wrong.
Okay, not so.
Yes. Now, there is when access is procedural. You get what I'm trying to say, and then there's also me wanting to just take the initiative. When access is procedural, then that means the institution places premium on what that procedure is going to do. Okay. You understand? But if it is me just taking discretion, that is just me trying to be a good pharmacist. So what I'm trying to say is that let's forget the fact that a pharmacist is trying to be good or not, and pay cognizance of the fact that the institution is not even paying attention to the importance of that procedure. Okay. There are some drugs I can't prescribe to a patient that is renally impaired. There are those calculations I will have to do to a patient that has hepatic problems. How do I know a patient that is hepatically impaired when I can't even have access to the case file? When all I get to see is just the prescription. Do you understand? You might not know as a doctor, you might not even know that, oh, okay, maybe this medication is excreted via the kidney. I'm not saying that you guys are clueless about it.
Okay, you should know as a doctor.
Do you understand? But I'm saying that you can't have such holistic knowledge about the medication like a pharmacist will.
Yeah.
Do you understand?
Or you have to at least to the
Yes.
So you should have to be therapeutic level.
Do you understand? Good. But the eye to detail I would pay to a drug is different from the eye to detail you would pay to a drug. I don't know if you get what I'm trying to say. So, which means I feel, and I'm of the opinion, that pharmacists should have access, you understand, to case files of patients. Not because of anything, just so we can have an idea of the patient's history.
And then add access to the history. Then what could have seen, what should simply be done, is that the way the lab forms are designed.
Okay.
In which a brief clinical history.
Okay.
Okay, good. Then or the radical querying querying this. Then that would just solve it. And not a full access to, I'm not saying you don't have access to the case note, of course, it's being own. But in that case, that is simply an administrative issue. Which
I am not disproving. Do you get?
And it has nothing to do with me.
No, of course, I agree. But I'm saying that it shows that the institution is not paying cognizance to the importance of that procedure.
So our pharmacists pushed for it.
Pharmacists have pushed for it in several cases. Okay, I've had the opportunity of interning in a private hospital. I won't mention the name now. You understand? And things like this are done. Okay, so fine. The system is completely digitalized. So doctor writes prescription and sends to the pharmacy. So before the patient gets to the pharmacy, we have literally seen the history, the prescription. You get? There's a chat box there where we can literally chat up the doctor. You understand that? Okay, we feel this and this and this is this thing. Okay, change it to this, change it to that. And that is done instantly. And your patient is safe. Okay. Do you understand? So, for example, there was a time a patient came, she was in her first trimester of pregnancy, she had cough, and then the doctor prescribed a drug that contained carbamazepine. Oh. You understand? Which is not safe, at least in the first trimester. Do you get? Now, we did not know how long the patient was gone in pregnancy until we saw the case file. You understand? So, if a doctor was writing a prescription, would you even have thought of including that?
Of course not.
You understand? Mm-hmm. Which means if we are giving that patient that drug, something else would have resulted.
That's saying that.
Do you understand?
It's simply an administrative issue.
Exactly.
Which I think the one of the that should be pushed for is not or might not be access to case notes, because the truth is this: if you start having access to case notes, you'll be tired. Okay. What you simply need is not the case notes.
No, what I'm saying is having access to patient history.
Good. That's simply that in the prescription. Okay, there is maybe an accompanying. Okay, this is the condition, especially in the hospital setting, because if you are taking the prescription outside, you might not want people to know that this is what is shared.
No, definitely.
But within the hospital setting, the what should be simply put is that on the column, okay, there will be a brief history, okay, gravida, this, paralysis, or querying AKI, or cough in pregnancy. So I think that will solve that. And it is so it has nothing to really do with doctors doing this or that or whatever. And since so far some hospitals are doing it, it means that there is no standard impediment against doing it.
And that is just a part of the things when I said some of these things are politics. Now the hospital I mentioned is a private hospital. Sure. And I made it say top. If I mention the name, you probably will know the hospital. It's one of the top private hospitals in Nigeria. You understand? And so I feel like even one of the reasons why these things have been done there, I'm not saying, it's probably because of the caliber of patients they attend to. I know that there are some people that when you attend to them, any error is a serious problem. You understand? But my question is, are these things being done even in public hospitals?
Most of them are not digitalized, and most of them don't have all these things that you said. Okay, because what you said is actually a function of state-of-the-art technology. It's a function of electronic medical recording. Okay. The question: how many of them have electronic medical records? Okay. Sometimes the issue I have is that sometimes the problem that is a problem of the country, we seem to place it upon doctors. If the hospital has EMR, electronic medical record, all these things will not be, there won't be issues. In a place like FMC Abeokuta, I know they do electronic medical records. You input the patient's conditions, input everybody sees it, or every staff in each of the units they see it. So in that case, this is not, you don't feel be an issue that will be brought up in terms of doctor issue, because it has nothing to do with me as a doctor. It is simply a problem of the country and an administrative problem. So in that case, what should be pushed for is that let there be an EMR. If there's an EMR, in fact, each state or the nation itself should have an EMR. Should have a general database that if I come to your hospital in Lagos with my security number,
Yes,
or
you should be
wherever
able to
number
access.
You can access my history from wherever I might have been, accessing treatment. So it is simply a problem with the nation and an administrative problem. So bringing it forth that pharmacists don't have access to case notes and linking it up with maybe some doctors don't. I think it shouldn't be a matter that the doctor should have any blame.
But I feel like the issue of still having access to even even access to patients, I think it's just recently that issue was a bit not even say resolved. I'm talking about ours.
Okay.
In particular now. I wouldn't even call it being resolved because I feel like the kind of access pharmacy students even have is not access.
Okay.
As it were. Do you get? Because whether we like it or not, both medical students and pharmacy students are trained towards providing services to one person, the patient. Do you understand? So it's high time we all understand that pharmacy has gone beyond just dispensing drugs and saying take one money one night. You understand? It's